welcome here to episode number 4. We're jumping into knee anatomy, which is definitely one of my more favorite joints to study. I think just because I've seen more knee injuries in my time. I've had knee injuries in my career. And I think a lot of people who get into PT probably at some point had a knee injury. It's just a big part of the process. So with me, as always, we got Vince. Vince, say hello.
Oh, hello.
Let's jump into it. So we're going to start with describing the joints. We'll do some skeletal structures. We'll talk about the ligaments and the capsules, the innervations, the musculature surrounding the knee, the mechanics. And then after this episode, we'll get into some pathologies, treatment, and then we'll go into some BFR stuff coming up. So primary joints of the knee, we have our tibiofemoral joint, which has its medial and lateral compartments. We have the patellofemoral joint, and then we also have our proximal tib fib, which is near the knee, but it's not really associated with. The fib head does have connections to the things crossing the knee joint, so it does play a role, but the tib fib joint isn't really involved with the motion. Primarily is the skeletal. We'll start with the skeletal structures, and we'll start with the primary articulations in the knee, which starts with the femoral condyles. They're covered with articular cartilage. It makes it a lot smoother. Obviously, all joint connections, we want articular cartilage there. It's what makes it moves well and prevents pain. Those are going to rest on top of the menisci, which are sitting on the tibial plateau. That is basically also the tibial condyles. You have the medial and lateral condyles. They're also lined with articular cartilage, but the menisci makes things much, much better. They are shaped differently. So the medial meniscus is going to be more C-shaped, and that's because of its involvement in the screw home mechanism, which we'll talk about later. And then the lateral meniscus is more O-shaped. The design shape is really essential to that knee function. Like I was saying, it has to do with the locking home mechanism. Most of the time when we look at the knee, we just think, oh, it just bends and flexes. It's a hinged joint, but there is some transverse plane motion, which is involved with that medial and external rotation. And then moving down, or not necessarily moving down, moving to the posterior aspect, there is a giant notch in between the the medial and lateral femoral condyles. And you can see that here on the graphic there, which we'll have those posted up. I'm talking without seeing them, but we will have that posted so you can see it. But there's a giant notch. And what that does is it creates some room for the ACL and the PCL to exist and provide our anterior and posterior translation resistive forces. And then it also basically creates a pocket for their existence. And those extend from the intercondylar notches into the intercondylar eminence, which is the mirror version on the tibial plateau. So in between the condyles there on the tibial plateau, there's an eminence there with a couple of roughy spots, which are where those tendons insert because they're pulling on that bone as they resist forces and creates those notches. On the anterior side, we have the trochlear groove, and this is going to be more important to the patellofemoral joint, and it's how the patella tracks, which we'll talk a little bit what the patella sides and facets look like there in a bit, but basically the patellofemoral joint uses the trochlear groove, and that's how we have knee tracking, if you want to call that, during dynamic motion of the knee. On the anterior aspect of the tibia, we have our tibial tubercle, which is where the patellar tendon inserts, which is just the most distal end of the quadriceps. We may talk about it later in the pathologies, but if you've heard of Osgood-Schlatter's, that's where there's a really, really big prominence or like inflammation on the anterior aspect of the tibia. That's the Osgood-Schlatter's disease. And what it is there's a lot of excessive forces that pull on that and make it bigger than it needs to be or bigger than what it normally looks like. And then lastly, the patella. So the patella is a really interesting bone. It originates within the quadriceps tendon. It ends up dividing what we call the quadriceps tendon and the patellar tendon. The base of the patella is on the superior side, which is, kind of weird. But so that's going to be a flatter region. It's on the superior aspect. Opposite that is the apex. It's going to be more triangular, more pointy, and that's on the inferior side. And then on the deep side of the patella, it is all lined with articular cartilage. It's really thick, about 4 to 5 millimeters, according to the Donald Newman text. And there's a little ridge in the middle. We have a medial facet. We have a lateral facet. There is an odd facet, too, on the most extreme medial side. And those basically exist. So as the knee goes through flexion and extension, different parts of the patella are creating that articular contact and where the forces divide. So we need to have a really, really thick articular cartilage to protect there. That is the skeletal structures. What's up next?
So ligaments and capsules come after that. So if I can talk about them.
Okay.
Okay. So ligaments, capsules. So in the knee, there's multiple layers to this. We all know there's the stratum fibrosum that's made up of dense fibrous connective tissue, and it closes the tibiofemoral ligament or joint and patellofemoral joint. And then we have the stratum synovium, and then we're going to have the medial and lateral retinaculum fibers, and that is just oriented to keep the patella in place as we move about. And it's made up continuous fascial layer from the quadricep and IT band. And then inside the capsular ligaments, we have the medial cruciate ligament. So medial cruciate is going to resist that valgus force, that medial force. So lateral to medial. All right. And then we also have the lateral cruciate ligament, and that's going to resist the lateral forces, typically medial to lateral. And I believe the lateral cruciate ligament is smaller when you palpate it along the structure. And that's going to be more because we tend to come in contact a lot more with those valgus forces because they're more exposed to our environment, if you think about it. Because medial side, most often going to have contact with the other knee. So not as, I want to say dangerous. Not the best word, but it works. Then we have our patellar ligament. So that's going to connect at the apex of the knee to the ischial tuberosity, tibial tuberosity,
Tibial tubercle.
tibial tubercle. And then, you know, it's all the tubercles, tuberosities.
It's all the same. Tuber.
It's hard to it's hard to differentiate sometimes. Then we have our oblique popliteal ligament and our arcuate popliteal ligament. And these are going to connect the fibular head, specifically the arcuate popliteal ligament, that are going to connect the fibular head to the tibia and over to the lateral condyle. It's a bigger sheet that kind of just overlaps and keeps that nice and secure up to the tibia. And then we have a couple of our internal ligaments, specifically our ACL and our PCL, anterior, posterior cruciate ligaments. Anterior, we probably all are very familiar with this one. That's going to resist anterior forces. And then the posterior cruciate ligament is going to resist posterior forces. Okay. And then surrounding that, we have our meniscus, which those are going to help increase surface area on the knee to help for better traction of the condyles on the tibial plateau. And Vito, was there more stuff you wanted to say about this?
Yeah, if we want to get into the nitty gritty about it, just because the meniscus is so vital to the knee function, and we see a lot of pathology with it, especially when it comes to any sort of ACL tears or other ligamentous instability issues, the meniscus is probably going to have some involvement. So if we want to get a little bit deeper into it, so there's free ends on both meniscus. There's the anterior horn and the posterior horn, which is just in relation to how it sits on the tibia. And then those have muscular attachments. So there's ligamentous attachments, there's muscular attachments, and those all, when they're contracted, provide some level of stability to the meniscus itself, as well as providing stability to the joint. Specifically, the quads and the semimembranosus, those attach to both the lateral and medial menisci. On the lateral side, there's the popliteus attachment, which is really important in that screw home mechanism. Again, we'll get to that as we get a little bit deeper, but the primary role of these menisci is to attenuate compressive forces, stabilize during motion, and they do have some role in proprioception. And then the blood supply to the meniscus is unique. So on the most, let's call it deep to superficial, just because it is deep. So the deeper you go within the knee joint, there's less blood supply. And so if you get an injury there, less opportunity to heal. So we call that the white zone. As you move towards the middle of it, we call it the pink zone. Depending on your age, trauma to the knee, and some other prognostic factors, you may or may not see some healing in this pink zone. And then there's the red zone, which is the most superficial edge of what the menisci is with respect to the knee. And that's usually going to have a lot more blood supply and therefore a lot more healing, which both knowing where the tear occurs, knowing the type of tear that occurs is all super, super important to both us as physical therapists and orthopedic surgeons on how we want to manage any sort of meniscus injury. It's really nice if we don't have to do a meniscal repair, just because that takes so much time and limits mobility. Now, if it's a excision of some meniscal tissue, we as PTs get to jump right back into rehab. There's no repair. If it's just cut out, then we don't have to worry about anything. We can get into whatever the other management is. But if there's a repair, we have to wait for it, which causes a lot of other impairments during that healing process timeline. So knowing where the meniscus injury occurs and knowing the type of tear that occurs is really, really vital for both us PTs and orthopedic surgeons.
All right. Well said. So I think that's going to be it for ligaments. Do we want to talk innervation and some musculature?
Yeah, let's get into it.
Cool. So lower extremity primarily is going to be from the vertebral segments L2 to S2, okay, and specifically thigh and calf area surrounding the knee. We're not going to go too much into the hip musculature, even though there is some overlap, but we'll get into that when we cover the hip. So the main nerves we're going to see in this area are going to be the femoral nerve, sciatic nerve, and the tibial portion of the sciatic. And so from that, if you want to think about which muscles innervate from those, pause the video, give yourself a little test, and then we'll see what you remember. So in the musculature, first thing we have quadriceps groups. That's going to be made up of 4 different muscles: vastus lateralis, medialis, intermediate, and rec fem. So those muscles are all innervated by the same nerve as femoral nerve L2 through L4.
Hey, question. Can you bias the contraction of VMO with respect to the rest of the quad muscles?
Oh, that question. The VMO myth.
The VMO myth?
The VMO myth. So I feel in gym culture, almost, I would say, it's popular to try and reposition your leg during a leg extension to target the specific muscles, specifically the little heads of vastus medialis and lateralis, and in hopes that you somehow engage that side a little more. But that's impossible. And that's because the entire quadriceps group is innervated by one nerve, and you cannot isolate those muscles independently from that nerve, because as your body tries to activate it, it's going to engage all of those muscles because it's one nerve.
Sorry, putting you on the spot.
To put it simply.
Yeah.
Yeah. But yeah, so if you want to try to isolate it, good luck.
Be my guest.
Be my guest. If you can do it, that's amazing. Show me how.
We're going to study you.
And then,
unicorn.
Yeah, unicorn. So next up, we have the sartorius, okay? And that's going to also be innervated by femoral nerve L2 through 4. That's going to help with some leg flexion because of where it inserts on the knee, kind of goes around, and it's going to help with some external rotation. Then after that, we have our adductor magnus, specifically the hamstring portion. I know this is more of a hip dominant muscle that it acts upon, but because of the size and where it's going to insert, the adductor magnus has a hamstring portion that acts as a knee flexor. and that's going to be innervated by the tibial portion of the sciatic nerve, which is primarily L4, and then we get some L5, S1 in that. And then moving to the posterior side of the thigh, we have our hamstring group. Uh, those are made up of three muscles: semimembranosus, semitendinosus, and biceps fem. Biceps femoris is going to have two heads. So if you want to think about it as four muscles, you can, but it's still going to be all innervated by the same, which is going to be that tibial nerve L5 through S2. And we all know what the hamstrings does, help flexes the knee. And then after that, we have the popliteus. Popliteus is going to be the main contributor in that screw home mechanism, which we're going to talk about in a little bit. And that's going to be primarily innervated by tibial nerve L4 through S1. And then lastly, a couple things are going to be our gastrocnemius. Now, I don't include soleus because the soleus does not cross the knee joint and therefore does not uh, help any sort of knee flexion or motion. So,
Can you go back and just start over after you said the soleus doesn't cross the knee joint? Uh, I don't know if it was my side that's lost you or if it was your side, but just to make sure that's recorded.
okay. So, like I said, uh, I isolate gastrocnemius on the knee because the soleus does not actually act on the knee because it inserts on the tibia and never crosses the joint. So, has no involvement anatomically. So gastrocnemius gets its own platform in this case. I feel like they're more often than not clumped together. And then gastrocnemius is going to be innervated by tibial nerve S1 through 2. And then, did you hear me talk about plantaris, Vito?
No, I didn't.
Okay. So plantaris is a very small muscle, as I try to recall from anatomy. It's very much like all tendon, and it has a little bit of muscle mass. Mainly going to be innervated by the tibial nerve S1 through 2. And those are going to cover all of our muscles for the mechanics of the knee, which we're going to jump into right now.
Cool. All right, let's talk about some mechanics.
Yeah.
Knowing all the muscles are great, but knowing how they work is even better. So we know it's a hinge joint. The primary motion of the knee is going to be the flexion and extension. We discussed a little bit that there's some external and internal rotation that occurs at the level of the knee at the joint line. One of the interesting things, so most of our information is coming from the Donald Newman textbook. We got it. That's what our textbook was for biomechanics. What our textbook, we alluded to that textbook in our anatomy course. The axis of rotation about the knee. So it's a medial lateral line. Basically, stick a pencil through your knee. That's the rotary point. It shifts as we go through flexion extension. Newman talks about how it may affect, why we show different torques at different angles from the same muscle groups. But it is necessary to consider as a PT, especially when it comes to measuring forces about the knee, knowing that that line is going to shift. And it also becomes really important when it goes to bracing too. So it talks about how you need to find the most average point of that of the axis point shifting just to prevent abrasion on the surface level, so the skin. But it is just kind of funny. So as the condyles move, that axis rotation shifts. If we look at it from a postural assessment, as we should be doing in almost all assessments and examinations, you're going to see some normal genu-valgum. That means that the angle of the femur and the tibia, so say this is the leg, and you should have some pointing of the knee towards the midline. So the knee should come together just a little bit. It's about 5 to 10 degrees, or if you want to say it from measuring the bigger angle, it'd be about 170 to 175 degrees. So their genu-valgum is normal in individuals. There should be some minimal genu-valgum. Then normal range of motion of the joint, we see there's roughly 5 to 10 degrees of hyperextension, and then flexion is anywhere from about 130 to 150. If you're looking at an impaired side, you're obviously going to compare side to side, and that's going to tell you if it's normal. So if you have an impaired side and unaffected, it compares to the other leg. We have our open pack position and our closed pack position. Closed pack is going to be that full extension. We don't have the open pack position listed. Is it 25?
Yeah, so 25 degrees of knee flexion is going to give you that loose pack position.
Okay,
So the least amount of contact between the condyles and the tibial plateau.
got it. Okay, so open pack at 25 degrees flexion, closed pack at full extension. Then our closed chain kinematics. So we talk about everything as which joint is moving on which. If
Are you
we're
still
in
there?
closed,
Did you freeze on me?
I can hear you. Can you not hear me anymore? Can you hear me?
Okay. You may be having some connective issues.
Can you
I
hear
did
me now?
not hear that last statement you made.
What
Yeah.
was the last statement?
Uh, After I mentioned loose pack positioning for the knee,
Okay. So
whatever you
yeah,
said following.
like Vince said, 25 degrees of flexion is that loose back position. It's the most wiggle room, the least articulation. Closed back position is going to be in that full extension. Moving on to closed chain kinematics. So we think about all of joints moving with respect to each other. So there's two levers. If we're going to talk about closed chain, that means that tibia is locked in place on the ground. And so we're talking about the femur. So if this is the tibia, this is the femur. It's the femur moving about the tibia here. So the condyles on the femur, they're convex. As they move forward, we're going to see an anterior roll. So the femur is moving forward, and then at the joint line, there's a posterior slide, and that's what's giving us that knee motion. And that flips when we go to open chain. So if you think about that quad extension machine, you're sitting on your bum, your femur sitting on top of the chair. Now the tibia is going to move against, and so we're going to see an anterior roll and slide of that tibia on top of the femur. Am I saying that right?
Yeah. Can you give me some examples of closed kinetic chain, open kinetic chain?
Oh, yes. My favorite movement of all time. Uh, Back squats or any type of squat. Your tibia and your ankle, like so your foot's staying on the ground, it's not moving. You're moving your hips down, your knee is flexing as you're dropping into that squat position. All of that motion is the femur occurring about the tibia. So the tibia is the stable point, and the moving arm is going to be that femur. Then as we move back up, it shifts. So if we're going into knee extension, anterior roll, posterior glide. If we're going into flexion, it's a posterior roll, anterior glide. And then if
Okay.
we go
That
to,
is that's the closed
that's
kinetic chain.
closed chain. Closed kinetic
Uh-huh.
chain. Feet aren't moving, body's moving about the tibia. Open chain, tibia is moving about the femur. So those feet are up in the air. They are out in space. The patellar function. So one of the reasons that the patellofemoral joint is so important is that it shifts the moment arm of the was it the of the quad tendon. So basically, it pushes the distance of forces that it's applying, and it actually applies a compressive force to the anterior aspect of the tibia and femur, posterior aspect of the patella, and it allows for an increased efficient contraction, an increase in force production by just a short movement of that patella away from the inside of that joint line. Now, there are cases of people without patellas being able to perform, but the amount of force production that you're going to get is just going to be not the same. And then the last biomechanical function that we really should talk about is going to be the locking mechanism. So as you're going into full extension, whether it's open chain or kinetic chain, you're going to have some rotation that occurs. We're going to talk about, or I'm going to think of it from that squat mechanic point. So the femur is what's moving about the tibia here. When you're going into those last 30 degrees of extension, this is where we start to get that rotary force or that transverse plane movement. And it's an external rotation of the tibia, meaning the tibial tubercle is moving. The femur is internally rotating, but it looks like, if you were an open chain, that the tibial tubercle is rotating towards the outside of the body. And so that femur is turning inward, and it's all occurring there on that, is it the medial condyle? I believe it's the medial.
It is.
Is that the C shape? Yeah. So the lateral aspect of the femur, so if we're going to assume this is the right leg and I'm facing you from my right position, The lateral aspect is locked in, and as we go into flex here, that femur is locking into place into that internal rotation. And so that's that popliteus function that's pulling that force that allows for that final rotation. And they are inseparable. You cannot have external rotation at the knee internally caused dynamically unless you are going through some flexion and some extension. They are inseparable. And then for flexion, it just reverses. So you're going to see an internal rotation of the tibia or external rotation of the femur as we bend that knee joint into a flex position.
All right.
Cool.
Well said. That is everything for the biomechanics. The knee's as intricate as it is also very simple when you try to compare it to more complex joints. I guess joints that allow for more degrees of freedom.
The shoulder,
hip, ankle,
cervical spine.
yeah, list goes on. But yeah, so I guess we can wrap it up.
Yep.
Short one today for this episode. Didn't have much to cover with that. It's going to get a lot more interesting when we get into some of the management and treatment for common knee pathologies. So put us on double speed for this one and get to that other episode. Should be coming out soon. Thank you for listening. If you made it this far, please like and subscribe and share our videos. Trying to get some more people educated on this stuff and help them in their journey.
And stay tuned to the Instagram page. We're going to be a lot more regular with that going forward, trying to present some management techniques and some exercises. What we wanted to create a couple series. What were those series? And we'll reiterate this when we go to the next episode. But what were the series that we wanted to create?
Right. So gonna start posting a lot more reels and stuff. We just gotta start recording those. We have one in editing right now. And my idea was to have a couple different series to go off of that'll give us a lot of content. First one's going to be rehab series, so that's going to be the first episode we pop in, and those are all going to be related to each joint as we cover them in the podcast. So we're going to do a couple of shorts on ankle rehab, and we want ankle strength. We're going to have ankle mobility, and then we're going to have an overall form series, which that's going to be more movement related, kind of going into like squats, deadlifts, and proper mechanics for that to keep you safe and increase gains in the end.
Gains.
Yeah, gains. So those are going to be the series that we post a little more consistently. And if you guys have certain movements that you want to see or feel that you're restricted in some way, let us know and we'll try to make a little short related to that.
Alrighty. Till next one.